Welcome to Ask Dr. Geier Live. Wherever you're watching, hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help you look, feel, and perform your best regardless of age or injuries. It is that one time, that one place every month that I answer your orthopedic injury questions, orthopedic surgery questions, rehab, recovery, regenerative medicine questions. So ask those at will. I will stay as long as there are questions. I say this every month, and every month I see that it doesn't work. But if you're watching on YouTube, please leave your questions in the chat, which at least on desktop will be on the right, not in the comments below the video. Those don't come through Restream, which is how I get this out to YouTube and X. And so leave them in the chat. I will not see them in the comments. Then I see later that there were questions there, and it's too late at that point. If you're watching on X, sometimes the questions come through, sometimes they don't. So if I'm not answering your question, come over to YouTube, watch it there, leave your questions in the chat. As always, please remember, this is not medical advice. I'm not giving you medical advice. I'm giving you information about an injury, about a surgery, about a type of recovery or type of treatment, regenerative treatment or otherwise, that you can use to basically understand that more, maybe talk to your doctor about it more, but I am not telling you what to do. I haven't seen you, I haven't examined you, I haven't looked at x-rays, looked at MRIs. I am not your doctor, you're not my patient. You are welcome to come see me as a patient in Charleston. There's ways to do that, and a lot of times we can do a short Zoom consultation where we can sort of talk about your injury or whatever it is, your condition, and then I would tell you what I would do for patients with that if they came to Charleston. I'm happy to set that up. There is information in the description below this video about how you can contact me, and we could potentially set that up. So if that is something that interests you, certainly reach out that way. Georgia says, hello, it's good to see you as always. A frequent viewer of this show makes me very, very happy. All right, we will get started. And like I always say, I will stay as long as I need to. That can be sometimes 45 minutes or close to an hour, and sometimes that can be 5 to 10 minutes. It is a beautiful, beautiful, beautiful day here in Charleston, and I can tell you very clearly that when we're done with questions, I'm going to get out of here and try to enjoy the day. So for what that's worth. All right, Sharon Miller says, do you recommend removal of hardware after a tibial plateau surgery? So that's a great question, and I will get to the answer to that, but just in case you're watching, you have no idea what a tibial plateau fracture is. So this is a model of the knee. You have obviously the patella, the kneecap, quad tendon, patella tendon, get that out of the way. The femur is the thigh bone, the tibia is the shin bone. The tibial plateau is the top of the tibia right below the knee. It's part of the basically weight-bearing structure of the knee. And the reason that potentially matters is that very few tibial plateau fractures can be treated without surgery. It's very rare because the fracture is almost always displaced and it extends into the joint, and that would lead to arthritis if it heals not perfectly. So it's almost always fixed. It's usually a plate and screws. Occasionally it can just be a couple of screws, but that's pretty unusual. Occasionally it's an external fixator where there's metal bars outside of the body and then pins that go into it. That's typically more of a short-term thing than long-term, but there are some long-term treatments with external fixators, but generally it's a plate and screws. This is what I would say. Typically, you don't need to have that hardware taken out. It's really more a matter if it's symptomatic. Now, I know that there are some people that feel fairly strongly taking them out may decrease the risk of future problems. There aren't really, to my knowledge, good studies showing that that hardware leads to problems such as the development of arthritis down the road. So as long as it's not bothering somebody, I would say you could leave it in. The problem is, for a lot of people, especially thin people, not a lot of muscle in that area, it's just skin and soft tissue, subcutaneous tissue, it does bother people, and so they end up going in to take it out. The surgery itself is not that bad. There's probably going to be a period of limited weight bearing after that hardware removal because, again, you've got now screw holes that have to fill in with bone. So a lot of times, at least with most orthopedic surgeons, trauma surgeons would limit that type of thing after surgery. All right, let's see. All right. Try to see. Piru, I may be saying that wrong, is coming from the Indian Ocean, Mauritius Island. Very, very cool. I'm always impressed, and Georgia, I know, comes from Greece, and I get people from all over the world, and that makes me really happy. Subluxation of the sternoclavicular joint, weakness and pain, ended up having sternoclavicular joint reconstruction. I did those a few times earlier in my career. There aren't many people that do those. Figure of 8 augmented with fiber tape. Very cool. See, 14th week post-op, cracking, popping, quite scary. Yeah, I would imagine so. And I'm sorry, I can't read all of this. I'm not going to subject everybody to that. Cracking, popping. Yeah, I don't know that necessarily that's a sign of anything worrisome. When you limit motion, you get sort of artificial mechanics. Again, not knowing in your case, and this would be tricky, it'd be a better question for your surgeon, but that's probably not necessarily a bad outcome. Again, what you're trying to eliminate by reconstructing those ligaments is that the end of the collarbone sort of popping back and forth over the sternum, and that surgery does relatively well at that. Now, does it lead to arthritis of that joint down the road? Potentially. Honestly, that's probably a better outcome than instability of that joint. But having said that, it may not be that. It could be, movement of some early scar tissue as you go through a range of motion, something like that. I wouldn't expect that's something that I'd worry about, but again, that's kind of hard to say. Generally, and this is not just the sternoclavicular joint, generally orthopedic surgeons don't worry about popping, cracking of joints. You can have that without arthritis. I know that's something that we always think about, where you have, like, say, the knee, you going through a range of motion, and if now that cartilage is not smooth or the underlying bone is not smooth, that would lead to popping, grinding, what we call crepitus, and it certainly can, but you can have that without arthritis. I mean, what I tell patients a lot of times, go find a girls' high school soccer team, if you're the coach, let's just say, or a parent, put your hand on one of the girls, or all the girls' different patellas, put them through a range of motion. A quarter or a third of them you'll feel what we call crepitus, and they have no arthritis going on in their knee. It's related to how patellar tracking, and this can be seen in the shoulder and a number of other joints. Where we get concerned about, as orthopedic surgeons, about popping or cracking is if it's painful, and then you want to try to find a structural cause for that pain and for that popping, for what that's worth. All right, Scott says, can degenerative disc disease in the back travel to the neck? So I get that question from military veterans a fair amount that have degenerative disc disease of the back, and they wonder if that caused their neck and vice versa, from a causation standpoint related to the military duties. I don't know any orthopedic surgeons that would say that one can cause the other. There's one study I know of that does show an association. So people with cervical spine issues more likely to have lumbar spine and vice versa than somebody that doesn't have one or the other problems. But I don't know any way you could say that it causes it. That would be a tough thing to say. Now, from a patient standpoint, not a military and nexus letter type of thing, could you have both? Absolutely. And I see that in a lot of people related to just the nature of the aging process and things like that. But typically one does not cause the other. You don't see the problem jump from one place to the other. Degenerative disc disease, this gets a little more into the regenerative medicine world that I do now in regenerative orthopedics, is essentially the arthritis process, just with different structures. Instead of inflammatory cytokines and degradative enzymes breaking down the articular cartilage and bone, say in the knee, it's doing that to the intervertebral discs, it's doing that to the ligaments, and yes, to a lesser extent, the vertebral bodies, the bones. So it's the same process going on, just at different structures. Gabrielle from Eastern North Carolina. I love North Carolina. I went to college in North Carolina and lived in 2 different cities in North Carolina early in my life. Not Eastern, unfortunately, but love North Carolina. Striker plate in my forearm, wondered what they're made of, if they're MRI safe. So there are different metals that are used to make plates and screws. There's stainless steel, which is still largely what most orthopedic surgeons use for trauma, but there are titanium ones, and that depends a little bit on the company. I don't honestly know off the top of my head. Stryker, again, I've gotten away from surgery as I pivoted to orthopedics. What was the second part of that question? If they're MRI safe, typically they would create a metal artifact. It's not that that's going to cause you any problems in terms of, people talk about pacemakers and they reset the pacemakers and things like that. It's that they can still sort of get pulled on by the magnet and cause pain, but more importantly, from a diagnostic standpoint, they would scatter the image and make it very hard to see whatever the issue is. Now, again, if it's, say, an MRI of the forearm, so where that becomes an issue, if somebody's got a couple ACL screws in their knee, and then you want to get an MRI of their knee after that to look at issues, those screws are going to create a metal artifact that makes that MRI very hard to read. Now, most people wouldn't need it. I don't know why you would need an MRI of the forearm, so that wouldn't necessarily be an issue. Metal in your body for an MRI of something else, I wouldn't think would be an issue, but again, it depends a little bit. I think my guess is titanium would be better than metal, and if it's a distant MRI, especially if you can do an extremity MRI or something like that where your whole body's not in the magnet, I would think that would be okay. But again, it might be a question worth asking the surgeon and finding out specifically what metal that is. All right. Piro says, how long do you think rehab's required to regain function in the arm to normal daily activities? Well, again, I only did a handful of those surgeries. There aren't many people, at least in the United States, that do sternoclavicular surgeries because, again, that's right by, well, not again, but it's that collarbone into the top of the sternum, into the collarbone, and there's a lot of bad structures under there. The ascending aorta coming off the heart, one of the biggest blood vessels in the body right there. The esophagus is right there. And so most orthopedic surgeons don't tackle that. It was certainly a nerve-wracking surgery. But if done well, that can do well. Typically, that I would say till you're normal, probably about, and this is not, again, medical advice, but it'd be about a year. But most people could start doing more aggressive activities somewhere in the 3 to 6 months. You just keep getting less pain, keep getting stronger, keep getting more of your motion back as that process goes on. All right, that looks like all we've got. Very, very appreciative that you're there. I greatly appreciate it. My next two Ask Dr. Geier lives for November and December are scheduled. I think it's November 22nd and December 20th. If you subscribe to my YouTube channel, you will see those there. I will put those in the playlist at the front so that it'll pop up on the homepage, but you can go ahead and mark to be notified if you're a subscriber, and I would appreciate it if you are, and I will see you then. Very excited. If you do want to come see me in Charleston, South Carolina, I can't do full-on Zoom treatments with people outside of North and South Carolina. I don't have medical licenses there, but we could potentially do a Zoom consultation where we decide if it's something I can help you with, and then you would come to see me in Charleston. If that's something you're interested in, there is information in the description below to talk about how you could potentially do that. So it'll give you a link to reach out to me, and either me or somebody on my team will help set that up. Hero says, thank you. You are so welcome. All of you that are here, very, very appreciative. I look forward to seeing you next month in Ask Dr. Geier Live. I hope you have an amazing weekend. Take care.